Hello, everyone. My name is Snehal Desai, and um, in a minute, I'm just going to go over some quick cardiovascular concepts, um, just for your review. Um, it's just a little bit of stuff that I wanted to talk to you about, particularly when it comes to understanding mechanisms of actions of many of the medications, especially for those used for the heart um, and other organs in the body, other different types of disease states. Um, it's important to recognize the different categories of drugs or the classifications and to realize or to see the uses of these medications, especially when you're going for any sort of exam that requires um, clinical um, section, knowledge type um, material. It is important to realize that um, you know not every drug is going to help a patient. In other words, there might not be a medication that works um, just the same as another medication. Some medications will work better than others. And then there are some medications that um, may also alter the effects of other parts of the cardiovascular system. So when you're looking at medications in terms of their mechanism, you can actually see a little bit more as to if this medication were given to the patient, will it actually effectively help, um, reduce or prevent, um, further, damage to any cardiovascular organ, like such as a heart, or maybe will it help with the blood pressure more effectively? Um, so, um, the approach in these couple of sectional reviews is really to go as a question answer approach. We're going to talk a little bit about the medications more in depth as we approach each question, as you would on any type of uh, pharmacy board exam or any kind of even medical exams um, that will kind of engage you as if you're talking to a healthcare worker or even a patient. So I hope that these slides will help you understand the um, clinical aspects of um, in understanding the clinical concepts of how these medications will help patient in achieving a therapeutic goal. So let me walk through some of these concepts with you all. First of all, these are some bullet point highlights that I believe are important, especially when it comes to the cardiovascular sections in the pharmacy um, uh, guides, or like when studying for pharmacy boards or any of that that is relevant in the pharmacy world. So you can see here, these are the basic concepts you're probably going to have to learn in terms of the cardiovascular section of an exam, understand the adrenergic receptors. Now, when it comes to adrenergic receptors, you will have to probably go a little bit above that and see where adrenergic comes from. Um, you can think of adrenergic like alpha in beta blockers and beta agonists and alpha agonists, alpha blockers. Um, One thing I would recommend you all to do is definitely take a look at what medications fall in which of those adrenergic receptor groups. Um, that will kind of illuminate or give you an idea as to um, what it can do to either reduce the blood pressure, increase the blood pressure, and helping the patient those kinds of ways. So, and some of these medications deal with adrenergic receptors. In fact, there's quite a bit of them. So it's important to understand that. The other thing is, it isn't relatively used as much, but it's important, especially since it has some role in terms of the cardiovascular literature, is the PDE enzymes or the PDE receptors. Um, there's a question in one of these slides that deals with the PDE3 receptors. And so I put it here in bullet point form for your understanding of how it relates in terms of like um, platelets and platelet aggregation, those kinds of groups. Then the AT1 or the RAS system, where you have the angiotensin enzymes that are involved in the systems, particularly when it comes to high blood pressure. You have this one enzyme here, which some of you may have heard of, cyclic AMP. When there's increase in cyclic AMP, there's usually a decrease in platelet activation aggregation. So that's something you might want to look into and see how it is triggered and preventing certain clotting events as and prevention of certain types of diseases. Potassium channel, calcium contractions. Notate these differences. Potassium and calcium. Yes, calcium is used as a way of contracting the muscles and all. But when you're looking at things like arrhythmic systems, you're actually looking at more of like the heartbeats and the heart rhythm rates, tachycardia, those kinds of things. So you're going to look into it as like a more of an electrical approach here. And so it's important to realize some of the differences here, particularly when you're looking at cell groups and cardiac cell muscles, looking at the cardiac electrical impulses and those kind of systems that deals with the potassium channel. And going more into it down another bullet point, you see here von Williams classification system, which there's like mainly the four classes: the sodium channel blockers, you got the beta blockers, potassium channel blockers, and then you have the fourth part here, which is the calcium channel blocker. So take a look at the von Williams classification as well. The next thing I want to highlight is particularly about the heart. Now, you probably heard of this somewhere in your textbooks. Um, understanding the differences between preload and afterload. How hard is the heart um, stretching when it's being filled with blood, and how hard it needs to work to pump it out of the heart. So, like, think of preload like it's, you know, preparing, preloading, loading it into the heart, and then taking it out of heart is after the load. And so, those kinds of concepts are important to understand. In relation to that, you had a heart failure rejection or reduced ejection fraction, and then the heart failure with preserved ejection fraction. Um, Similarly, but this one is more of like the pumping. Um, you have to also look at the ejection fraction rate. It's less than 40%, then it's obviously a reduced ejection fraction. If it's greater than 60%, it's a preserved ejection fraction. And typically, failure to eject it versus, you know, stiffness of the heart muscles in, uh, you know, which is reducing the relaxation of the heart. So, taking a look at those differences is important. Clotting factors. And one of the important clotting factors, or one of the medications that play a role in clotting factors, especially something like warfarin. Warfarin is deal with the vitamin K or um, V-core, which is vitamin K epoxide oxidase, which definitely when it gets vitamin K goes through a recycling mechanism, and it's actually typically used as part of the clotting factors. You have the protein C, which is a factor one, but then you have this word. I'm going to say it now so you guys might be able to remember it, but the word SNOT, if it comes to your mind, is you can recognize that as factor 7 for S, 9 for N, 10, you can think of O as 10, and then 2 for T. So it's not is a good way of remembering the clotting factors, especially when it comes to the warfarin. So take a look at that. Then the last thing here, the nitric oxide. There's some role in nitric oxide that some medications will help in relaxation of the vascular smooth muscles. So I thought of pointing out some of these different types of bullet points for you all just to take a look at, and as a refresher as you're studying for um, exams or even while you're in practice. Um, so hopefully this kind of helps a little bit in those refreshers. Let's look at some questions here. First one's dealing with hypertension. A 58-year-old patient with hypertension, type 2 diabetes, has blood pressure of 152 over 94 millimeter mercury despite lifestyle modifications. Which medication is preferred as an initial therapy because it provides both the blood pressure reduction and kidney protection? So there are 4 choices here. The first one is metoprolol. And metoprolol, as I mentioned earlier, it's important to realize the classifications again. Metoprolol is essentially your beta 1 blocker group, okay? So when you're looking at a beta 1 receptor on the heart or in the kidney, the metoprolol is typically going to use and antagonize that receptor there, and eventually reduce the heart rate, and also prevent, in the process, prevention of renin release from the kidneys. So that's important. And also to notate that there are certain other things about it that should also be notated, but this is one of the relevant things in terms of the blood pressure. All right, we'll just pause for a minute.
I'm going down 5:36 if you want to come.
What?
I will go around 5:30 or 6 if you want to come.
Okay.
You just give even help to me and mom, okay? When we are just moving the bed.
What?
You just went for a shower.
Yeah.
You can just help me to put it on bed.
Okay.
Me and mom are just moving the bed.
Okay.
You are just losing your own life.
Yeah.
Okay, then do whatever you want to do now. You just lie with me. You just turn up the computer, you won't use it now. You are just using it. Why you lie at me?
I'm using it right now because what else to do?
Yeah, so you told me you won't use it. You just shut it down. You will not turn it on. You just turn it on. You just lie with me.
I'm not lying.
That's what you did.
I'm doing educational project here, okay?
What you told me before, you just shut down the computer and you won't turn it on now.
Yeah, well,
then why you lie at me?
Okay, I don't want to shut it down, okay?
I don't like the people who lie with me. You just do whatever you want to do, okay?
I'm not lying.
That's what you did with me.
Okay, well, I said by mistake.
Yeah, so you do whatever you want to do. From now I won't talk with you. That's how it will go.
Why?
Why? That's a good option for me.
No, why won't you talk to me?
Yeah, what's the point of talking? Nothing.
We can talk.
I don't want to talk. You just busy on your life. Just do whatever you want to do.
Okay. All right then.
There's no point. I just enjoy my life alone. You enjoy your life alone. That's how it will go.
Okay. Well, let me finish what I'm doing.
Because you don't want to do any of the other thing. This is not your job. And just lying, I don't like the person lying. And then it will be my fault. So it's okay, it's my fault.
It's not your fault. So, I just want to show you all a little diagram here of how the beta 1 medication blocks the receptor. Now, these receptors can be pretty much anywhere in the body, but the main ones are especially in the heart and also the kidneys. You would probably see the beta blocker or beta receptors there. So, in this question, its relation is referring to kidney protection and blood pressure reduction. But you don't see much of that with a when it comes to metoprolol. And metoprolol comes in two different forms. They come as metoprolol succinate and metoprolol tartrate. And metoprolol tartrate is especially typically used for more so with blood pressure reduction than metoprolol succinate. Um, Metoprolol succinate is more heart related, and it's typically used like an extended release as a day um, once a day thing. Um, so although it does provide blood pressure reduction, um, you probably won't see much of it as a kidney protection. So this probably will not be your answer here. The next one here on the list is lisinopril. Lisinopril works in the RAS, which is the renin aldosterone system. And lisinopril typically, when normally when blood pressure gets too low, the kidneys release a enzyme known as renin. Renin gets released, it goes through the blood, it gets um, in contact with the liver, which releases a which makes the protein angiotensinogen. It's The liver actually, this angiotensinogen is to convert the renin to angiotensin 1. And angiotensin 1 then goes straight to the lungs, and the lungs are uses this enzyme called angiotensin converting enzyme, which helps in the conversion from angiotensin 1 to angiotensin 2. And then it binds to the AT1 receptor and causes vasoconstriction this way. Specifically, um, when there's efferent vasoconstriction um, around the kidneys, and that's where the blood pressure will kind of occur. So normally the lisinopril is used to block that conversion between angiotensin 1 and angiotensin 2, and it's would more likely be used for kidney protection. The next one here is clonidine. Clonidine is just straight um, alpha 2 agonist that it binds to in the brainstem and causes an overall reduction of sympathetic outflow, which will decrease the blood pressure effect overall. The last one here is hydralazine, which is typically used as a relaxation of the smooth muscle in the vascular system. The next one here deals with heart failure. Patient with heart failure, ejection fracture, which you can see here, the ejection fracture is around 30%. Is receiving guideline-directed medical therapy, which medication has been shown to reduce mortality in heart failure, reduce ejection fraction. So there's four choices here. Letter C, we kind of already talked about the RAS system, so there isn't too much to talk about. Sacubitril is kind of just also kind of helping with vasodilation, blocking that neprilysin, which definitely will help increase the vasodilation there. The other ones here, like the digoxin, which is going to typically help with um, the arrhythmics parts. And like when you look at things like digoxin, um, it binds to and inhibits the sodium potassium ATPase pump. So Normally, when there's sodium potassium ATPase, it pumps sodium out of the cell, and then there is um, increase or decrease in the sodium. So, but when you need to get a little more contraction, especially when there's heart failure, you need something like digoxin. So digoxin is going to block that pump. So there is more intracellular sodium and calcium. And calcium is the main contracting um, part of it. So it's important to understand how digoxin works. It also slows the sinoatrial node firing and the atrioventricular node conduction as well. The next one here is the furosemide, which is typically used right at the thick ascending loop of Henle as a diuretic, and that usually blocks the sodium potassium 2 chloride cotransporter group and increased urine production occurs, um, and more sodium stays in the urine. So then there's reduced blood pressure and reduced edema this way. One thing that's important for a patient, if you have a clinical case question where furosemide is being used, and especially when you're doing consultations with or discharge counseling with patients, is especially that um, it's important to tell them or let them know that it's best to take the water pill or furosemide in the morning rather than night, because then there is less chance of um, tripping or falling while having to repeatedly use the bathroom throughout the night. So best to take this in the morning while alert rather than taking in the evening. Um, the last one here falls in two groups. The diltiazem is a calcium channel blocker, but diltiazem and verapamil are both non-dihydropyridine um, calcium channel blockers, and so they have a effect on heart failure. In fact, um, it's not recommended for a patient having heart failure. Calcium channel blockers, you typically want to avoid any of that when it comes to heart failure types of calcium channel blockers, such as diltiazem. Um, as they block the calcium channel, and when you're blocking the um, calcium channel, calcium's not able to go in, there's less calcium, less contraction, then or it's not going to be any benefit there. So it's better to avoid that choice for this type of question. Next one here is arrhythmias. And as I mentioned earlier, it's important to note the arrhythmic groups. There's four types. There's class 1, class 2, class 3, class 4. Class 1 being the sodium channel, class 2 beta blocker, class 3 potassium, and then class 4 which is calcium channel blocker. And so you can probably already see some of these, but the question here is a patient presents with stable supraventricular tachycardia. Which medication is commonly used for rapid conversion to normal sinus rhythm? So, in this case, you need to understand that there is some kind of rapid heartbeat that's going on. So, and to convert it to normal sinus rhythm, you would need to use one of these kinds of medications. Now, when it comes to these drugs, you already know this is a low type CB, and then you also know that the digoxin is going to be used to increase the intracellular calcium. And then you have amiodarone, and we're going to talk about amiodarone right now. They block the potassium channel. So this one blocks K plus channels. And then this last one, adenosine, they bind to the A1 adenosine receptors. So what happens when the A1 receptors are activated? It's going to open the potassium channel. It's going to cause the potassium to leave the cell. Cell becomes hyperpolarized, and then the overall AV node gets slowed. So essentially, adenosine would be the most appropriate choice here. Um, because of what it's going to do in terms of the tachycardia part and resetting that system here. Then the next one here, patient with stable angina experiences chest pain during exercise. Which medication decreases myocardial oxygen demand by reducing heart rate? So there are four choices here. Of these four choices, you can probably eliminate one because it has no it has nothing to do with this question at all. And that last choice is D, ezetimibe. I'm sure you've seen it in pharmacy practice, and for those who haven't, that one is mainly just to reduce the cholesterol. And cholesterol in this case doesn't really have anything to do with the stable angina patients experiencing. Although there could be some similarities maybe there, but it's not really going to help with reducing the myocardial oxygen demand. Now you can see metoprolol as a rate decrease, or you can see aspirin maybe making a blood thinner, but it's not really going to work as much as like nitroglycerin, which is going to help with the oxygen demand reduction overall. And then this one is basically asking for which one is a high intensity therapy. So a patient with established ASCVD requires high intensity statin therapy. Which medication qualifies as a high intensity therapy? And there are four choices here: pravastatin 20 milligram daily, simvastatin 20 milligram daily, atorvastatin 80 milligram daily, or lovastatin 20 milligram daily. So if you see a choice like this, you might not see it exactly like this, but most of the other statins here, pravastatin and lovastatin, are not going to be in the high intensity groups. They are more low to intermediate groups. Simvastatin, more like intermediate. Rosuvastatin and atorvastatin would fall into high intensity groups based on the strains that they go by. Um, so in this case, the answer is going to be C, atorvastatin 80 milligram. And atorvastatin is interesting when it comes to statin medication. A couple of things. Um, it is used for reduction of cholesterol. It is used for increasing the LDL receptor activity um, by pulling the LDL from the blood and then um, lowering the overall LDL numbers this way. It blocks the HMG CoA to methylate um, conversion there. So it will work in that part of the liver. So um, it's pretty interesting. Um, though there's some theory where there was that some patients may experience headache. That's typically due to the properties of like the statins. Some statins are water soluble versus some are non-polar, and typically more of a non-polar would cross the blood-brain barrier and possibly lead to more of a headache. So that's in theory that it could occur that way. So um, don't think they're gonna trick you up on that kind of question, but it's good to know. A patient is taking warfarin, has an INR of 8.5 and active gastrointestinal bleeding. Which treatment is most appropriate here? So, um, for a patient who is on warfarin and has a very high INR, um, some of you might say that to hold warfarin only, but this patient may still need the warfarin as part of the therapy and treatment. Probably not the best choice here in this case. Protamine sulfate, it's not going to work where the warfarin is working. This medication is going to be used to as like a kind of like an antidote to high amounts of heparin in the system and those kinds of things. Then you got idarucizumab, which is kind of like another one that will kind of be used against the dabigatran. Um, so in this case, you would initiate vitamin K plus the 4 factor PCC um, as an antidote, but you will not stop patient from taking warfarin because they may need it for the therapy, whether it's for NSTEMI or STEMI treatment, like a ST elevation, myocardial infarction. So it's important to note you might see like something like this. It could be a little bit tricky here, and you have to choose the appropriate therapy. So um, just wanted you to see that. And also remember the clotting factor SNOT, as we looked at in the beginning. This next one is a patient arrives at the emergency department within 2 hours of symptom onset and is diagnosed with an acute ischemic stroke. Which medication may be considered if no contraindications exist? So, stroke. Um, well, first of all, uh, these are some of the choices. They're all kind of blood thinners, but they're all going to be used differently. And this one requires more of looking at the recommendations, looking at the guidelines. In this concept, you see there are four choices: alteplase, aspirin only, heparin infusion, or clopidogrel loading dose. Um, they might not have a lot of information here, but when it comes to ischemic stroke, um, the best one to give patient is alteplase. And that's usually what it is. It's going to help with stroke prevention and also in the treatment process. The other ones are used in like later therapies, and you probably don't see things like heparin used as much or clopidogrel because those are more like if patient has a stent or is experiencing a deep venous thrombosis or deep vein thrombosis. Um, and aspirin is just going to only be used if used as a secondary treatment for a patient experiencing stroke or as an adjunct. This in this situation, your best answer would be dalteplase. If you had to guess, that would be your best answer too. Then the next one here, a patient with intermittent claudication due to PAD wants to improve walking distance. Which medication is indicated? And in this case, you have four choices. You have cilostazol, you have warfarin, you have digoxin, and you have um, diltiazem. Now, I personally don't see um, this kind of disease state. You would look at it more like being used, for prevention of something, some patient having something the peripheral artery, and they need some, something to kind of loosen that platelet aggregation there. Um, Warfarin, on the other hand, is going to more likely lead to more of a um, breakage in like clotting factors, and in this case, you're not trying to um, cause or break up the clots in the blood. It's mainly you're trying to um, lessen the aggregation that's in the tissues leading to that intermittent claudication um, in the peripheral parts of the body. So um, diltiazem has nothing to do with it. Diltiazem is essentially just a calcium channel blocker and has definitely nothing to do with intermittent claudication at all. So that is definitely not going to be your answer. Neither is digoxin because digoxin is going to only help with the heart arrhythmics. So you might be left with two choices, cilostazol or warfarin. And if you had to look at it this way, um, you would more likely see warfarin being used more so with um, when dealing with issues with the heart um, than dealing with the peripheral artery. So just take a look. And they might have other choices there, but cilostazol is the approved indication for intermittent claudication. So just why I point that out. That's kind of just going to help decrease that platelet aggregation there by activating that cyclic AMP in the bloodstream. So hopefully um, that will kind of prevent future occurrences of this issue. Um, I think we talked quite a bit here. Does anyone have any questions so far? I see some of you will be taking the NAPLEX this year. Yes, you're welcome. Uh, I hope that all the videos that I have uh, posted here have been useful. I will continue to have these posted for you all because you know it's a tough exam, and um, you'll have to just go through. Um, if you're really cramming for this exam, you really want to get done with it. Best thing to do is look at the main points in every um, page of your book. Look at all the bolded, underlined words, um, and repeatedly ask yourself, um, these types of things. Why does this occur? What is happening um, in the process? What are some monitoring parameters I should be watching out for? Um, Things like AST, ALT elevation, should take a look at INR, should take a look at, um, you know, different types of, goals. There's probably a diagram when maybe one of your books or pages where you'll see like a chart that will have the therapeutic levels for each of the seizure medications. Um, I would say take a look at that, and all of those kinds of things. But these videos are made to break it down for you all to make it a little bit easier for you guys to understand the material a little better. So um, just take your time and feel free to ask any questions. You guys can comment on here if you'd like, or even use our Farm Stories Facebook page if you'd like to ask any questions on there. But thank you for watching. I hope this has been helpful to you all, and I'll see you next time. Thanks. Bye.